Today, so we'll be discussing quality improvement in healthcare in general, why it is needed and all, and with a special reference to anesthesia and perioperative management. But before we start, I would like to quote James Reason. In 1990 said, rather than being the instigator of an accident, operator tends to be the inheritors of system defects. Their part is usually that of adding the final garnish to a lethal brew whose ingredients have already been long in the cooking. And this is true for every healthcare person, but more apt for the anesthetist who is working in the operation theater. What does it mean is, operator means the person with whom the final lethal brew, that is the final process happens, which ultimately leads to some accident. But actually, there are so many system defects which have been in place much before, which lead to this accident. But usually the operator has been blamed. But generally, he or she is the inheritor of a system defect. We need to understand that a system that works is not about individuals. And this is another James Reason's Swiss cheese model of accident causation. What he proposed that before the final accident occurs, actually there are many steps which might prevent and which may get bypassed, ultimately leading to the harm. So there are many latent conditions like management deficiency, inadequate control, there are some physical failures like equipment failure, and then finally an unsafe act. When they all come together, the accident takes place. So generally we tend to produce only the active failures, the violations, the mistakes. But usually there is a background of many latent conditions and all these factors leading to final accident. So friends, what are the jobs of healthcare persons? According to Paul Battledon, who is the guru in quality improvement in healthcare, he says the healthcare person has only two jobs: to do his or her work as prescribed and to improve it on a daily basis. So we are going to discuss about what is the quality of care, why we need quality in healthcare delivery system, how do we deliver and sustain quality of care in our settings, what are the benefits of adopting quality improvement methodology in our day-to-day working, and what are the applications of quality improvement in the perioperative and anesthesia. So friends, health outcome in the lower middle class income group countries like India have improved in the past few decades. The bar being constantly raised because of the changing health needs and the growing public expectations and the ambitious health goal. And what we need is a high quality health systems that optimize healthcare in each given context by constantly delivering care that improves or maintains health. People need to value that care and trust them. And we need to respond by changing population needs. The first law of improvement is every system is perfectly designed to achieve exactly the same result it gets. So if you want to change the result, you'll have to redesign the system. Otherwise, if you continue to do the same, you'll get the same results. So what do you understand by quality in healthcare? I would have liked to be physical to have interacted, but I still feel that on Zoom we can still interact. So I wanted to know your opinions or inputs about what do you understand by quality in healthcare? So anybody can speak. What is their view of quality in healthcare?
I suppose quality in healthcare, this is particularly regarding anesthesia practice, which we do, is to provide the best possible anesthesia care, which means providing the optimum, doing the procedures with the best quality possible, maintaining that quality throughout the intraoperative and perioperative period so that there is no harm to the patient.
So you mean to say we need to practice evidence-based care, right?
Yes, sir.
Okay. Anybody else? What do you understand by quality?
Sujata says it is maintaining all aseptic precautions throughout the procedure.
So like preventing harm. Wonderful. Anyone else?
In some ways, if we can measure the quantitative analysis of the care that is provided, so you can make sure that the patient has got exactly what he wants. So maybe a feedback or something like that.
That's measuring the quality. But the definition of quality we are discussing, you're correct. That is part of measurement. So let me tell you.
It's like a standard of something which will be measured against some specific standard.
That is evidence-based care, na? Scientific. Okay,
Yes.
Wonderful. All of you are correct in some or the other way. Let us understand what is the WHO definition of quality of care. So WHO says there are 6 domains of quality. The first is safe, delivering healthcare that minimizes risk and harms and including and avoiding preventable injuries and reducing medical errors. Effective, providing services based on scientific knowledge and evidence-based guidelines. Timely, reducing delays in providing and receiving care. Efficient, delivering healthcare in a manner that maximizes resource use and avoids wastages. So, reducing waste is also a quality. Equitable, delivering healthcare that does not differ in quality according to personal characteristics like caste, creed, religion, color, socioeconomic status. And people-centered, that is providing care that takes into account the preferences and aspirations of individual service users and the culture of their community. So these are the 6 domains of quality of care. And the 7th domain we have recently added is the sustainability, providing the care which is sustainable, continuous. So in general, what is quality is the degree to which the results of the work you do match the needs you intend to meet, in short. So why we need quality improvement in healthcare? There are 8.6 million deaths that occur each year from the lack of good healthcare. And this is from the article in Lancet in 2018. Typically, we feel the people do not reach to the healthcare in time, or they don't have access to healthcare, and that is why the death rate is high. But what the data says is completely different. So out of 8.6 million, 5 million deaths are because of the poor quality of care. So 2/3 deaths are poor quality of care despite seeking the healthcare facility or the treatment. And generally, what we say is that workforce is at fault. Log काम ही नहीं करते ठीक से. But the commission found that it is not the workforce that is at fault. Then how to improve the quality? So what we usually do to address the quality gaps? Anybody? What we generally do to improve the quality of care?
We hold responsible many persons involved in the system.
We try to put accountability or the blames.
Yes.
Anyone else?
We must improve the training of the people.
Training.
We
Okay.
properly follow the checklist.
Correct. Training, education, checklist. Right.
Communication.
Communication, yeah. So generally the common solutions what we employ is we make guidelines and policy. We say infrastructure is not good, so we build infrastructure. Equipments are not there, we procure equipments. We feel people need training, we train the trainers, we monitor them, we incentivize them. अच्छा काम किया, incentive. काम कम किया, punishment. बराबर. Right. We hope that the digital solutions like apps or tablet will improve the quality of care, and at times we punish. Right. But friends, we have made various evidence-based guidelines, all societies, whether it's a pediatric, gynec, anesthesia, surgery, whatever. Okay. All professional bodies globally and India. But do guidelines translate to better care? Worldwide, there is a wide variation in the compliance to guidelines ranging from 9 to 30%. In India, we don't have the data. So, for middle-income countries like India, the compliance to the evidence-based guidelines is less than 50%, and probably this is a bold statement. It is much less than that. So guidelines do not translate into better care. Equipment law, you build the infrastructure, you train the people, you make guidelines, you incentivize, you punish them. That hasn't been found to improve the quality of care. Now, this is a slide demonstrating you the systematic review of interventions done to improve the healthcare worker performance. This also appeared in Lancet 2018. And the impact of that particular intervention has been shown in the table. The technology-based strategy, the effect size is only 1%. Printed informations like posters and all, 1.4%. Financial incentive, 1.2%. Only training, 10.3%. Online supervision, 14%. Training plus supervision, 18%. Quality improvement, 28%. And quality improvement plus clinical training, 56%. So simply making guidelines, simply doing training is not enough. We need to have something more. And the various training model, as somebody says, we need to train. Look at this table. If you give only lectures, today I am giving you some lecture. So you will understand it, but it will impact on your skills, 10%, but the application will be 0%. Demonstration, 30% skill acquisition, but 0% application. If you practice it, better effect, 70% skill acquisition, 20% only the actual application in the on-site. So coaching and review has been found to have the biggest. So if you learn, practice, and coach somebody and have feedback, then the effect is like your skills are 100% as well as the application is around 80%. So friends, the evidence-based intervention, the grade 1 evidence is increasing very, very fast. Our knowledge is improving very, very fast. New research is coming very, very fast. But the application of that research into practice is lagging far behind. And there is a big gap between what we know and what we do. And the gap is increasing very rapidly unless we act now. It will go on increasing further. And the biggest gap in your life is between what you know and what you do. And if we try to solve the problem from the same consciousness that created it, it is not going to work. You must learn to see the world anew. It will be insanity, sign of insanity, if we continue to do the same thing over and over again and expect different results. There are two types of knowledge. One which we acquire as a professionals, that is the subject matter knowledge, and the other is the knowledge of science of improvement, which is nothing but the interplay of theories of systems, variation, knowledge, and psychology. We need to combine the subject matter knowledge and the knowledge of science of improvement in creative ways to develop effective ideas for change. So what is exactly quality improvement is? Quality improvement is a systems management approach that healthcare workers can use to reorganize the patient care. Understand, reorganize the patient care at their level to ensure that quality does not get lost while translating from books and guidelines to the bedside point of care and patient receive good quality of health care first time and every time. It is a complete shift of approach from an individual-based system to a system-based care, from a fault finding to problem solving. And it primarily focuses on reorganizing the care within the existing resources through a process of redesign. Resources आएंगे, manpower बढ़ेंगे, अगर हमें सोचते रहेंगे तो quality तो बनती रहेगी. What are different approaches to improving the quality of healthcare? I will just label you what are the approaches. I'm not going to discuss for want of time. This is one model for improvement. It is based on 3 questions. What are we trying to accomplish? How will we know that a change is an improvement? And what changes can we make that will result in improvement? And then ultimately we test those changes on a small scale so that if there is any harm and we want to know how it works, and then we implement. Before we implement, like अगर चावल बना रहे होते तो just you take out 1 grain to understand whether it is cooked or not, isn't it? So you plan that you take out 1 grain, check it, study it, whether it is cooked or not, and then act accordingly, whether it requires further more time or not. Simple example. This is called PDSA, Plan, Do, Study, Act cycle. And Plan, Do, Study, Act cycle are the basis of all these methodologies. So Toyota, it uses the lean principle for waste. Six Sigma is useful for decreasing variation and defects. Audit, you know, but audit leads to tell you what is the current situation only. Kaizen is like another methodology where you go to Gemba, that is you do the process work, the leaders work, go to the processes of care and look at the processes. This is one simplified approach which we are training. It is called the point of care quality improvement. It consists of 4 steps. First step is the most difficult step, identifying a problem. Very, very difficult, I'm telling you. To try to understand, I was asked when I first attended this, what are the problems in your unit? And I was like blank. So I called Dr. Sunita Bhave from Delhi and asked her, आपल्याकडे काय problem आहे? So it is like that because we are not in the habit of maintaining data. So this was 7 years back. So identifying a problem, improvement is a team game. So forming a team, you must have a aim statement. Otherwise, you will wander here and there. Nobody will understand what we are doing. Analysis of the problem is very, very important. So and measuring the quality of care is also important to understand where we stand today and where we are heading. You need to develop some change ideas and test them on a smaller scale to prevent a bigger harm, and then refine them and then implement them. And then finally, the biggest challenge is another is once you improve, sustaining improvement. Remember, all models are wrong, but the practical question is how wrong do they have to be not useful? So all are useful. We need to have a creative mind in healthcare if we want to improve. What stops creativity in healthcare? It is performance goals, hierarchical problems, financial priorities, command and control type of leadership, competing demand, बाकी सारे बहुत सारे काम है, pressurized environment like in operation theater, disempowerment, fear that की जास्त काम मिळेल मला, work, more work, lack of motivation नहीं है, and then we are in comfort zone, चाललंय ना चांगलं, कशाला काय करायचं, बस. It is a team game improvement. we need to form a team and have a smart aim statement. We need to form a team of all the stakeholder, enthusiastic people involved, those who are involved in the process of care, which are trying to improve, those are influential, and then assign the role them. Have a proper aim statement which is specific to the problems, addressing the specific population. Have a measurement in process that which is simple to measure. It should be achievable yet challenging, it should be relevant, and it should be timely. So there has to be a time, otherwise it will go on wandering and wandering. Analysis of the problem is very, very important. Before you directly implement changes, you will have a lot of problems if you don't analyze. So if you jump to solutions directly, you will miss all this: sense making, engagement of the stakeholder, understanding of the current situation, data you will not have, you will not be able to understand what are the root causes proper. So all these you will miss. So don't jump to solutions. Measurement is an essential part of improvement. If you don't measure, you can't improve. Simple. In gods we trust, all others must bring data. So measurement helps to decide how we are progressing over time, helps to compare us with other units, benchmarking. So measurements is the foundation of improvement. Now for measurements we have some indicators. We need indicators. अब journey चालू है तो हमें पता चलना चाहिए किलोमीटर कितने किलोमीटर हो गए कितने बाकी. So like that we have a process indicator because we undertake many processes of care while delivering healthcare, and then outcome indicator, which are the result of what we do to the patients, what processes we carry out. For example, as far as surgeries are concerned, like number of patients operated. Now the process is patient has undergone surgery. So percentage of surgeries that have pre-op assessment done, or it can be a process measure can be percentage of surgery with appropriate use of surgical safety checklists. Related outcome will be percentage of unexpected ICU admissions, surgical site infection, post-operative pain and nausea. You measure it and you put it on run chart or a statistical process control chart, the data at a say different interval, which may be daily, weekly, monthly, whatever. And then you understand whether there is any improvement or not. Statistical process control chart is a more advanced tool, which will tell you whether you are improving or you are maintaining the same status quo, whether there is any special cause like COVID that's disrupted your problem. And once you remove that special cause, you are back to control again. So whether your system is in control or it is out of control, it will tell you. I told you about PDSA. You need to have a small test of change before you implement and modify the change before you implement them. I will not go into details of this. You need to have multiple changes finally leading to the improvement of care. There will be some changes which you will have to abandon. There will be many changes which you will have to modify, test again, and then finally implement. And there will be very, very few changes which will work in the first attempt. So whose responsibility is in quality healthcare? भाई मैं तो दूसरों के हॉस्पिटल में ओटी में जा रहा हूँ, मेरी जिम्मेदारी तो है नहीं. It's not like that. Quality improvement is the combined and unceasing efforts of everyone, healthcare professional, patients, and the researcher, the payer, the planner, the educator, to make the changes that will lead to better patient outcomes, that is health, better system performance, that is care, and better professional development, that is learning. The purpose of quality improvement theory is to provide the methodology to improve the care. It's a science. It's a proven science. Okay. The goal is of reliability, defined as the patient receive the care and wanted for the first time and every time. Why we do quality improvement? To implement the best practices in care, to bring about lasting improvement, to standardize the processes and structures to reduce variation, to increase the employee satisfaction and teamwork, to understand, to make our service user experience better. And there are many. Now, as far as intensive care or anesthesia is concerned, human factors play a big role. As such, they play a role in healthcare, but in these scenarios, it is very, very important. And what is CRM? That is Crisis Resource Management. Let us find out. Human factors is science of people at work. The WHO describe it as the study of all factors that make it easier to do the work in the right way. Understanding and applying human factors approach in health setting can enhance way healthcare is delivered and received. To experience the impact of human factors. But we rarely analyze whether it is a human factor in place, and we generally tend to blame the individual or the context for the outcomes. So this concept actually came from aviation crew resource management. So there was a major plane crash just because of the communication error that led to aviation industry to use this crisis resource management in their day-to-day practice, and As you can understand, if there is a failure in this, how many airlines will crash? But that rarely happens. But in our settings, the harm happens very, very frequently. And it consists of some technical and non-technical skills which lead to improved performance and safety. This was first adapted by an anesthetist called Dr. Gaba. So these are mainly the principles of crisis resource management. The first and foremost is call for help early. You need to anticipate and plan. You know your environments. Use all available information. You have to allocate your attention wisely. Mobilize the resources. Use cognitive aids. Communicate effectively. Distribute workload. Establish role clarity. So coming to what is situational awareness and how it is useful in OT. So situational awareness is nothing but परिस्थिती जाणावा, परिस्थितीची जाणीव. So it is useful for error prevention and performance improvement. It is like knowing what is going on around you, and most essentially, it's a non-technical skill. So you need to perceive what is happening, comprehend, compare, and then predict what can happen and what we are supposed to do. Very useful aspect, but it's very uncommon. Debrief is another technique which is a very, very useful technique. And we should always debrief, even if the things go very well, and understand why they have gone very well. And if there is an issue that was detected, we need to have a thorough debrief and ask ourselves question, was the communication clear? Were the roles and responsibility understood? Was the situational awareness maintained? Was workload distribution was equitable? Task assistance requested offered? Were errors made or avoided? What were resources available? We need to understand what went well, what we can improve next time, and what can we do differently. Another important is the communication. As Sujit initially rightly said, communication is one of the biggest problems in healthcare, and more so in this hot environment of operation theater, very volatile environment, where in case of emergency, we need to communicate very fast, and we need to use the protocol like S-bar. It is situation, background, assessment, recommendation. Situations like this is a patient at this moment, we are unable to intubate and ventilate. Background tell this patient is used for an elective sinus surgery. The assessment is what we have done. So we anesthetize the patient. We tried to intubate. We couldn't pass the LMA. Could not intubate. We are trying to back and forth. Patient is desaturating. I need your help. Recommendation is somebody is there. Recommendation that is I need help. I need a bed to be reserved in OT. I need tracheostomy like that. Another important principle is called Donabedian principle in healthcare. It is Donabedian, who is known as the father of improvement. He coined this principle. He said your structures, that is the infrastructure, equipment, manpower, and the processes of care leads to your outcome. We added another aspect to it, which is a very, very important aspect, that it's a culture or the behaviors. So structures, processes, and behaviors of the culture all together constitutes result in your outcomes. So this principle we used when we had an outbreak of gram-negative sepsis around 2.5 years back. We did many structural changes in our NSU. We audited many processes and improved them. But when we incorporated the behavioral change ideas, then and then only we could sustain and control that outbreaks. And since last almost 2 years now that we are free of infections outbreak. So coming to the quality improvement in perioperative care and anesthesia, what are the best strategies and practices? Quality improvement in anesthesia aims to enhance the patient safety, their outcomes, and overall efficiency. This involves systematic efforts to identify and address gap in care. So how can we approach quality improvement? So preoperative assessment and optimization. So all of you do comprehensive pre-op evaluations through history, physical condition, risk factor to tailor the perioperative care plans. You can have preoperative clinics where you can have established dedicated preoperative clinic for evaluation and optimization of for high-risk patient. You all are using risk stratification tools like the ASA and all, and categorize the patient risk. You all use some checklists to ensure safety protocols. Measures to prevent medications like standardizing labeling and double checking systems you can follow. Monitoring and reporting and learning from the mistakes or even near misses, even if it doesn't lead to harm, is a very, very important practice to improve our outcomes. Standardization is the biggest problem in India, standardization and a lot of variations in our processes. So use surgical safety checklist, as it is intended, not just a tick business or not after surgery, just feel it for the completion purposes. All those protocols and SOPs, you have to adhere to that and audit their uses. As far as intraoperative management is concerned, you all are using technologies such as capnography monitoring. So all advanced monitoring, you are doing it, following these SOPs for all the procedures. Use crisis resource management principles when you handle an intraoperative emergency. Very, very useful. For post-operative care, obviously, pain management, monitoring for complications such as nausea, vomiting, and respiratory depression is important. Use enhanced recovery protocols to promote faster and safer recovery. Continuous professional development is very, very important. So I am really happy to see that this is the 100th education activity by the Anesthesia Forum. We must commend the efforts of all those involved. Simulation is another very, very important part in improving your outcome. So you can use simulation to fund the training for rare and critical scenarios. Peer reviews from our friends and feedback from them is also another way of understanding what we are doing. We need to have a data on our outcomes so that we identify the trends and areas for improvement. Compare our performance to the benchmarks, nationally, internationally. Use your data for continuous quality improvement and improve the anesthesia care. Use technological integrations, like technology to good effect. Electronic health record, decision support system. You adopt technology and innovate for the good comes. Patient-centered care is very, very important part that we generally tend to ignore. Gather data from feedback from the patients regarding their anesthesia experience. Have a clear communication between yourself and the patients. Informed consents are very, very important. Ensure that the patients are fully informed and consent to the anesthesia procedures. How can we use quality improvement in anesthesia and perioperative care? Just ask these 9 questions. Does the problem, any problem that keeps people awake at night, problem, does this issue occur commonly? Is it from a chaotic system? Chaotic means the processes of care need organized nahi hai, systems need organized nahi hai, aise ठिकाणी आपण काम करतो आहे. So if it is a chaotic, nobody knows what are the equipment, how to undertake the processes. If we do not have more than 80% processes documented, how we are going to do in our system, then it's a chaotic system. Can your problem be improved? What has stopped you from improving the problem? Is the service or process undergoing any change? Does this problem upset people? And does the problem lead to avoidable cost? Can your problem be measured? So ask these 9 questions, you will find out what you can improve. So some anesthesia quality indicators, anesthesia-related mortality and adverse events like medication error, equipment failure, post-operative nausea, vomiting rates, pain management effectiveness, recovery room incidents like hypoxia, delayed awakening, unplanned reintubations, pre-anesthetic assessment completions, informed consent for anesthesia, adherence to safety checklist like the surgical safety checklist, anaphylaxis rates, and unplanned ICU admissions. These are some there. You may be knowing more than this. So quality improvement in perioperative care is a continuous multifaceted effort that requires the commitment of the entire healthcare system. Implementing these strategies can significantly enhance patient outcome, improve safety, and overall efficiency in the perioperative settings. You won't reach new results with old habits. Like the father of quality, Avis Donabiran said, ultimately the secret of quality is love. You have to love your patients, you have to love your profession, you have to love your God. It is not enough to do your best. You must know what to do and then do your best. This is what W. Edward Demings, is a statistician and a father of quality improvement, said. So knowing is not enough, we must apply. Being willing is not enough, we must do. So thank you very much.